next info bit is about the vertical sleeve gastrectomy. This operation goes by many different names. Sometimes you'll see it abbreviated as VSG. Sometimes you'll see it referred to as the gastric sleeve, and others will just call it the sleeve. The sleeve is in the category of restrictive procedure. So in a restrictive procedure, we just do something to help make your stomach smaller so that your portion sizes are reduced. And also typically hunger will be reduced as well. But all consumed calories still get absorbed. You just consume fewer calories because you're getting full earlier. Restrictive procedures as a whole have lower risk than malabsorptive procedures like the gastric bypass or the duodenal switch because they're simpler operations overall. Here's a picture of a gastric sleeve, and the first thing I'd like to point out is that calling it a gastric sleeve seems to imply that we're putting some kind of a device called a sleeve onto the stomach, and that's really not the case at all. What we do in a gastric sleeve is we remove this part of the stomach over here. We actually physically take it out of the body so that the remaining stomach is much smaller, and it's kind of like a long, narrow tube like a sleeve on a jacket. That's why it's called the gastric sleeve. We do sleeves with a minimally invasive laparoscopic technique. So if you choose this operation, you would have 5 little small tiny incisions. Altogether, they add up roughly to about 1.5 inches to 2 inches total in length. The operation time is usually about an hour, and the facility stay is short for a sleeve. Most patients will go home the same day or at the most an overnight stay. As I mentioned before, if we consider the risks of a gastric sleeve, it's going to be less overall than the risk of a bypass or a duodenal switch. However, the overall risks are the same, just in lower percentages. So bleeding is a risk of any abdominal operation and is a potential risk of a gastric sleeve, although low. The complication that's specific to sleeves, bypass, and duodenal switches are called staple line leaks. These are potential issues that can arrive due to the little tiny staples that we use to seal up the stomach. In about 1 to 2% of cases, one of these staples can leak. Typically, if it does happen, it's not until the 2nd or 3rd week after surgery. Most of the time, staple line leaks can be managed without surgery, but in some cases, another operation could be required to correct the issue. GERD can potentially be a problem, or gastroesophageal reflux disease, after a sleeve. Some patients who already suffer from GERD will see improvement after a sleeve. Some patients, their GERD will remain the same, but there are some patients who will see worsening of GERD. In terms of recovery, it's pretty quick for the sleeve. Most patients take 1 to 2 weeks off of work, and with your diet, we advance it along slowly after the sleeve. You do 7 days of liquids, 3 weeks of pureed food, and then you're on solids at the beginning of the 4th week. In terms of the follow-up regimen in the office, usually we'll see sleeve patients about 5 times in the first year, maybe typically twice in the 2nd year, and then usually about yearly thereafter. If we look at the results in terms of weight loss after a sleeve, we set a goal in our practice for sleeve patients to lose 75% of their excess body weight. So this would mean, for example, that if you weighed exactly 100 pounds over your ideal and you lost 75% of that, that would equate to 75 pounds. If you weighed 200 pounds over your ideal and you lost 75% of that, that would be 150 pounds. Typically, though, we see a dropping off in that percent excess body weight loss the higher a patient's body mass index is. So we may see more along the lines of 100 to 125 pounds in a patient who is actually 200 pounds over their ideal body weight, but it certainly does not hurt to set your goal high after surgery.